with a physical attack.
Uh-huh.
Really don't need an introduction because they're basically homegrown. I'm allowed to say that. Subham moved with us from Case Western Reserve, where he was a master's student. Then came here and completed his Ph.D. in my laboratory last June. And really has done a beautiful job on his Ph.D. thesis. All of this focused on the pediatrics aspects of electrocardiographic imaging. And through it all, he worked with Jennifer. Jennifer became part of the lab through marriage also. But before that, she really worked closely with Silva on all of the pediatric cases when she was a fellow here. Then went to Boston for 1 year at Children's Hospital and came back as faculty. So, Silva.
Thank you. Good evening, everyone, and thank you.
I forgot to say that Subham will be joining the ranks of Medtronic as of July.
Thank you for being here. In today's presentation, we'll look at the first ever application of the ECG imaging technique in the pediatric population. And in specific, we'll be looking at a very challenging and unique population, namely the patients with congenital heart disease and cardiomyopathy. I will actually talk a little bit about the introduction to ECGI and describe some of the preliminary work that we did in pediatrics, and then I'll hand it over to Jen, who will continue the rest of the talk. As we all know, cardiac arrhythmias continue to be a major cause of...
laser pointer there. That's right.
Thank you. As we all know, cardiac arrhythmias continue to be a major cause of death and disability throughout the world. And despite this, the only conventional non-invasive method of diagnosis of apparent cardiac rhythms is the 12-lead ECG. While the ECG has really passed the test of decades as a successful clinical tool, it suffers from certain limitations. First of all, ECG measurements are made on the body surface far away from the heart at a limited number of leads, and they often lack adequate resolution, sensitivity, and specificity. Electrocardiographic imaging, or as we call it in short, ECGI, is a novel functional imaging modality for cardiac electrophysiology that has been developed in Dr. Rudy's lab over the last several years. And ECGI can non-invasively reconstruct epicardial potentials, electrograms, activation and repolarization sequences based on a 250 electrode ECG and a thoracic CT scan. And this is a slide which shows briefly the outline of the procedure of ECGI, which is actually quite simple. The subject of the patient actually undergoes simultaneous body surface potential mapping from over 200 electrodes, which are applied to the torso in the form of strips as shown here. And then he also undergoes the ECG-gated CT scan, which provides us the hot torso geometry. And this information is combined with all the 250 electrocardiograms to generate electroanatomic maps of potentials, electrograms, and isochrones on the epicardial surface of the heart. And this block that you see here, called CADIS, consists of the software which involves all the numerical computation involved in this process. And CADIS stands for Cardiac Arrhythmia Diagnostic Imaging Software. To tell you a little bit about the theory of ECGI, the governing equation is the Laplace's equation, which is applied to the source-free volume conductor between the epicardial surface and the torso surface. We use an integral formulation of Laplace's equation, applying Green's second theorem, and then discretization by boundary length method to derive the relationship between the epicardial potentials VE and the torso potentials VT. And A is the transfer matrix which relates these two quantities and is essentially dependent on the heart-torso geometric relationship. ECGI thus constitutes an inverse problem of computing epicardial potentials from measured torso potentials VT. And these potentials VT are obtained from our multi-channel body surface potential mapping system. So with the ECGI problem, we actually start with 250 electrocardiograms on the body surface, And in solution, we actually compute cardiac electrograms at 500 or so points distributed throughout the surface of the ventricular epicardium. And from each such electrogram, we can actually compute the local activation time and the local recovery time and the activation recovery interval. And having determined all these quantities for all such points, we can actually create the 3D color-coded surface maps of activation and repolarization sequences on the epicardium. From the electrogram, the activation time is determined as the time corresponding to the sharpest downslope of the QRS, whereas recovery time is the time corresponding to the steepest slope of the T wave. And the interval between these two, the activation recovery interval, has been shown to correlate well with the local action potential duration in experimental studies. And this actually reflects the local repolarization properties. To give you a background on some of the previous work done with ECGI, there has been extensive validation studies, and these were mostly done in canines. Then there was validation in humans with data from intraoperative mapping. A preliminary report of human application was published as a technical report in Nature Medicine back in 2004, and later on, a more extensive study of ECGI in normal healthy subjects was published in PNAS. And these studies actually provided important control data of normal cardiac electrophysiology using this technique. There's also a study which used ECGI to look at the EP substrate and its modification through cardiac resynchronization therapy in a very heterogeneous group of adult ischemic patients. When I came to Washington University for my dissertation, one of the goals of the lab was to apply ECGI to the pediatric population, which was never done before. And based on the patient anatomy, we sort of divided the projects in the pediatrics broadly into two categories. The first class consisted of patients who had structurally normal hearts. And in this category, we had mainly patients with Wolff-Parkinson-White syndrome, where the goal was to non-invasively localize the pre-excitation site using ECGI, and also to study cardiac memory associated with pre-excitation in kids. And the second category consisted of patients with congenital heart disease, and these were patients with very unusual anatomy. And in this class, we sort of evaluated the capability of ECGI to accurately localize accessory pathway insertions in congenital heart defect patients with pre-excitation. And secondly, we also evaluated the EP substrate and intraventricular dyssynchrony in prospective CRT candidates with congenital heart disease. And this part, Jane is actually going to talk about later, while I'm going to focus more on this project, the pathway localization and cardiac memory in WPW. In the normal heart, the atrioventricular node, or the AV node, forms the one and only electrical connection between the atria and the ventricles. WPW is characterized by the presence of one or more accessory pathways or bridges between the atria and the ventricle, and these conduct impulses much faster than the AV node, leading to premature excitation of the portion of the ventricle. And this manifests in the 12-lead ECG in the form of extremely short PR intervals and slurring in the initial portion of the QRS. This is called delta wave, and there are also these unusual T-wave inversions evident in some of the leads. Sometimes the pathway, together with the AV node, can form a reentrant circuit for a very fast tachycardia known as supraventricular tachycardia. Clinically, management of symptomatic WPW patient involves transvenous catheter ablation of the accessory pathway. To tell you a little bit about cardiac memory in the context of WPW. Cardiac memory essentially refers to changes in ventricular repolarization which are induced by and which persist for minutes to months after a period of altered ventricular activation. Such altered activation may be generated by pacing from conduction disorders like left bundle branch block, or even from WPW pre-excitation. And the mechanism of memory is believed to involve transcriptional changes that alters the expression levels and kinetics of cardiac ion channels like the transient outward current, the L-type calcium current, and the delayed rectifier, which are the primary determinants of cardiac repolarization. WPW provides a naturally occurring model of long-standing altered activation from an accessory pathway. And this is true especially for patients with persistent pre-excitation who have been paced from a long time from their accessory pathway. And this natural model can be used to study the electrophysiologic changes due to chronic pacing. The ablation of the accessory pathway and restoration of normal sinus rhythm provides the model of activation and repolation changes and their time course following cessation of pacing. The objective in this study was to use ECGI to localize the region of pre-excitation for guiding ablation and to image activation and repolation patterns pre-ablation and at different time points post-ablation to study cardiac memory associated with pre-excitation. The population included 14 pediatric patients with an average age of around 12 years. They were all symptomatic with persistent manifest pre-excitation and were referred for catheter ablation. They're also free from congenital heart disease with transthoracic echo demonstrating normal systolic function. For the purpose of localization of the axillary pathway, we divided each atrioventricular annulus circumferentially into 12 one-hour clock divisions. The anteriormost aspect of each annulus is assigned a 12 o'clock position, the posterior aspect is assigned a 6 o'clock position, and so on. The mouth of the coronary sinus and the tricuspid valve would be a 5 o'clock position. And the different clock positions are shown here in the standard LAO view of the fluoroangiogram of the valve plane. Thus, a 3 o'clock position here on the tricuspid valve would be, on tricuspid annulus would be a mid-septal location. A 9 o'clock on the tricuspid annulus would be a right lateral location, and so on. Here we show an example of localization of a right posterior pathway from our ECGI epicardial potential map in one of our patients. And this map actually shows the spatial distribution of epicardial potentials 15 milliseconds after onset of the delta wave on the body surface ECG. And we observed a region of intense negative potential minimum developing on the right posterior aspect of the tricuspid annulus, as shown here in blue. And this actually corresponds to the epicardial potential breakthrough of the pre-excitation wavefront. We localized this pathway at 5 o'clock on the tricuspid annulus, close to the mouth of the coronary sinus. And this panel here actually shows the site of successful ablation in the LAO view of the fluoroangiogram. And the red arrow indicates the final position of the ablation catheter. And this was a pathway right at the upper lip of the coronary sinus, close to our ECGI prediction. Here we show the ECGI activation maps, pre-ablation and post-ablation in the same subject. Pre-ablation, we saw early activation in the right posterior aspect of the tricuspid annulus, shown here in red. And the electrogram from the pre-excitation region has a predominant negative S wave reflecting early activation. Whereas post-ablation, the activation sequence is now reversed. We have late activation here in the right posterior and posterolateral RV base, as shown in blue, and this is consistent with the pattern of normal human ventricular activation. Also, if you look at the electrogram from this region, it has a marked change in morphology. It is now a predominant R wave, which reflects late activation. However, notice the change in the T wave. Before ablation, the T wave was inverted, and now the degree of inversion sort of becomes even more. And this is something which we'll study in a bit more details later on, the phenomena of so-called T wave memory. Here we show yet another example of pathway localization from ECGI potential maps. However, in contrast to the previous example, here we see two discrete potential minima early on during the onset of delta wave, and these get replaced by two maxima, shown here in red, during the initial phase of repolarization. And these maps taken together led us to think that there are two separate left-sided pathways located at 3 o'clock and 5 o'clock positions on the mitral annulus. And this was actually later independently verified and confirmed during the catheter ablation. This table shows the ECGI predicted location of the axillary pathway in some of our patients and the correspondence with the site of successful ablation. We could predict the correct location of the pathway with a fair degree of accuracy in most cases, except for mid-septal pathways. This is because the ECGI reconstructions are essentially confined to the epicardial roof of the septum, and we cannot image electrical activity inside the septal wall. To show you some of the data on cardiac memory, here I actually present the activation recovery interval maps in the patient with the two left-sided pathways, the example we saw earlier. And the maps are shown pre-ablation, 45 minutes post-ablation, a week, and a month after ablation. Before ablation, in the pre-excited rhythm, there is an area of prolonged action, prolonged ARI in the pre-excitation region as shown in red. And there's also a very large apex to base ARI dispersion of about 100 milliseconds. In the normal case, the apex to base dispersion of repolarization in the left ventricle is around 40 milliseconds. But here we have at least 2 times the higher dispersion. And 45 minutes after ablation, though we show that the activation map has been restored to normal, the same abnormal ARI distribution persists with those same high ARI gradients between apex to base. The ARI gradients are sort of reduced but still abnormally high at a value of 80 milliseconds a week after ablation, and they are reduced further and restored to normal value of 40 seconds a month after ablation. And the inset actually shows the changes in the T wave of the electrogram in the pre-excitation region in the course of this remodeling process. Before ablation, we saw an inverted T wave. After ablation, the degree of inversion increases. The degree of inversion lessens after a week, and a month after, we have almost a flat T wave with a small positive deflection. We saw that abnormal repolarization persists with high dispersion post-ablation and gradually returns to normal over a time course of a month, consistent with long-term cardiac memory. The conclusions for this part of the study, we saw that ECGI can locate pathways non-invasively within an hour to guide ablation, and post-ablation ECGI can confirm return to normal sinus rhythm non-invasively. And the same concept of using ECGI pre-ablation for localization of ablation target and for post-ablation follow-up can be applied to other VT, other substrate-based ablation like VT, focal VT, etc. Even for atrial arrhythmias. We observed that ARI in the pre-excitation region is greatly prolonged due to action potential remodeling, leading to very high base to apex dispersion, which results over 1 month following restoration of normal sinus rhythm. And this demonstrated the presence of long-term cardiac memory in these pre-excitation patients. And with that, I will sort of hand over to Jen to continue for the rest of the talk.
So now we're going to make the segue. So we've seen that ECGI worked in pediatric patients. We then wanted to see if they worked in congenital heart patients. And what we decided to do is then look at pre-excitation in those congenital heart patients. We knew that we could find pre-excitation using epicardial activation maps. But before we do this, I thought we should start with some basic terms and just kind of define ourselves. So the univentricular heart. We're going to kind of use this whether you're talking about a hypoplastic right ventricle, demonstrated here, where you can have a defect of the tricuspid valve, pulmonary valve, or some sort of malformation of the right ventricle. Or hypoplastic left heart, where you can have deformation of mitral valve, aortic valve, and a small left ventricle. Regardless, whether you have a hypoplastic RV or an LV, you end up going down the staged surgical palliation for single ventricle patients. And the staged surgical palliation is essentially done to separate your blood flows into a pulmonary and a systemic blood flow, and that's eventually what you're aiming for by the stage 3. The first stage, however, is just to secure a source of pulmonary blood flow. Since you only have one ventricle, that ventricle has to be the systemic ventricle, whether it's right or left, doesn't matter. You have to make that systemic. So what you have to do in the interim is secure a safe and reliable source of pulmonary blood flow. There's a couple different ways to do it. For the purposes of this presentation, it doesn't really much matter. Suffice it to say, it happens very early on, at day of life 3 to 4 usually. And this is the first stage, or the Norwood procedure. The second stage, or the Glenn shunt, this is where it starts getting interesting. This happens around 4 to 6 months. And what you essentially need to do is redirect SBC flow, or all the blood returning from the upper part of the heart to the pulmonary arteries. So this, in a small child, is about 2/3 of the cardiac output that now goes directly to the pulmonary arteries. You do this because you want to offload the volume overload on that ventricle. So you leave kids like this for about 2 years, and then you finally bring them back for their Fontan, which is where you take the rest of the blood flow, all coming from the IVC, redirect that up to the pulmonary arteries, and now you have 2 fully separated circulations with all of your SBC, IVC blood going straight to the pulmonary arteries before coming back to the heart and getting pumped out. Another very interesting congenital heart abnormality, specifically interesting to electrophysiologists, is Epstein's anomaly. This is a congenital malformation of the tricuspid valve. So this is normal, this is abnormal, where you get apical displacement of the septal and posterior leaflets of the tricuspid valve, and so you get what we call atrialization of the right ventricle. So all this that should have been right ventricle now becomes right atrium. Epstein's anomaly is particularly interesting for electrophysiologists because they have all sorts of EP abnormalities. They often have WPW, often have right bundle branch blocks, often have multiple pathways. And then the third one that I just want to introduce you to very quickly are congenitally corrected transposition of the great arteries. This is where you have L-looped or inverted ventricles. So you have a systemic right ventricle, you have a pulmonic left ventricle. Some people would argue you should leave this alone. Some people do all sorts of fancy operations for it. Regardless, we know that long-term, these patients who have a systemic right ventricle go into heart failure. And very interestingly, the data has shown that pacing these patients will put them in heart failure earlier. So there's something very unusual about this substrate that we really don't understand yet. This group is at particular risk for developing, out of nowhere, complete heart block. So they're often a group that needs pacing, but it's dangerous to do so. So now that we've kind of introduced our terms with congenital heart disease, let's talk about our first case, a 12-year-old girl with a univentricular heart. Her diagnosis was tricuspid atresia, so she had a small right ventricle. And then she had her Fontan procedure. She showed up in class 3 heart failure with an ejection fraction of 20%. She was not in good shape. By echocardiogram, she had a very, very dilated ventricle, and her ECG showed great excitation. So we have these ways of taking the delta wave and putting them through an algorithm to predict whether or not, where we can find the pathway. So we put her delta wave in, and in fact, it came out to be a right lateral pathway. So we took our patient to the EP lab because we think that WPW in patients with heart failure is a problem that needs to be ablated. So before that, we took her for ECGI, and we saw that the earliest site of epicardial activation was on the right side of AV valve, which, if you remember, was atretic, so difficult. And it was in an anteroseptal location, putting it up close by the ascending aorta. When we took her to the EP lab, we created a cardio map, and a cardio map is an endocardial activation map. And we mapped the ventricle in pre-excited sinus rhythm, and we in fact found the accessory pathway was exactly where we had predicted it by ECGI, in the septal region. Unfortunately for this patient, because of her anatomy, we weren't able to actually successfully ablate it. We only got transient successive ablation lesions, but her delta wave persisted, and she actually ended up expiring. Case 2 was a 16-year-old female with a history of palpitations. She showed up in clinic and had her echocardiogram, and lo and behold, had Epstein's anomaly. So she had this inferior displacement of the valve, normal function, mild TR, but her ECG shows pre-excitation. They all do. And if you map her delta wave, it's suggestive of what they call in the literature a sub-epicardial, which is basically an epicardial or somewhere in the coronary sinus accessory pathway. And so we took her also to a EP lab. Before we did that, we did an ECGI, and the ECGI predicted that the pathway was going to be located right on the right AV valve, which we would expect with patients with Epstein's, and in a posterolateral location. And when we did her cardo, or her endocardial map, we in fact found that the successful lesions were in the right posterolateral part of the annulus, and fluoroscopy, this is the RAO and LAO views, confirmed that location, posterolateral. Post-ablation, we repeated her ECGI, and we showed that her activation patterns have returned to normal-looking patterns. So, what can we conclude from this? ECGI could be used to successfully predict early epicardial activation in patients with congenital heart disease, and that the usual algorithms for predicting where these pathways live in kids with congenital heart disease fall apart. This brought us to our next study, and this is my area of interest, and that is cardiac resynchronization therapy, or CRT, in pediatric patients with congenital heart disease. So what is CRT? CRT started on steam in like 2000, I believe, and essentially it's just a biventricular pacemaker, is what the adults call it. We don't call that because half of our patients don't have two ventricles. We call it CRT. What you essentially have in an older patient, you have 3 leads, one in the atrium, one in the right ventricle, and one lead that you snake through the coronary sinus and out to a left ventricular epicardial location. So if you look at x-rays, you say this top patient patient over here. In fact, he has a CRT system with an endocardial left ventricular lead. Or more commonly in our patients, because when you have congenital heart disease, your coronary venous anatomy is often incredibly abnormal, so you can't really thread a lead in through the coronary sinus. What you end up having is a transvenous atrial lead, transvenous right ventricular lead, and an epicardial lead, which you can actually see these two little buttons here. That's what an epicardial bipolar lead looks like. You can see that on the lateral as well. So CRT, the indications, the adult indications are low ejection fraction, less than 35%, wide QRS, New York Heart Class 3 or 4, despite optimal medical therapy. This has all been done in adults, it doesn't apply to kids. And if we actually look at pediatric heart failure patients who get CRT, 71% have congenital heart disease. This is not an insignificant proportion, this is huge. What we're finding is we're getting better and better at taking care of these newborns, and they're growing up, and now they're 15-year-olds who have heart failure, so we better think of ways to treat these. Only 15% of these patients have primary cardiomyopathy. This is radically different from what the adults show. 13% had congenital complete AV block. So why are pediatric patients different? Aside from the size, the substrate is just very different from the adults. So when we talk about the evaluation of a pediatric heart failure patient for cardiac resynchronization therapy, just in general, let's take ECGI out of the picture for a second. I think of it in three parts. The pre-implant, or the patient selection. Who's going to respond to CRT? This is a procedure that is not without risk, especially if you have to put an epicardial lead. It's an anesthesia, it's an operation, it's a thoracotomy. The adult data shows that 20% of patients are non-responders. In pediatrics, it's up to 30% patients are non-responders. So we're clearly not selecting patients correctly. That criteria that I showed you a slide ago just isn't working for the kids. Then the actual active implantation. Where do we put these leads? Well, the pediatric surgeons and the electrophysiologists said, well, 180 degrees apart, and it only stands to reason. Probably not quite the case. And then do we do epicardial versus transvenous leads? Finally, after they've been implanted, what happens to all these measures of dyssynchrony, the electrical dyssynchrony, the mechanical dyssynchrony, which we'll get into? Can you optimize these patients? And what should we be learning from our non-responders? Because there's something we obviously are missing. The QRS duration is something that the adults and the pediatrics use routinely as a surrogate marker for electrical dyssynchrony. So we say that if the QRS is long, you have electrical dyssynchrony, you're going to benefit from CRT. And in the adult patients, they have this left bundle branch block pattern. And I have to say, honestly, in pediatrics, you see it less than 5% of the time. Kids don't get left bundle branch blocks. They just don't. When they do, it's incredibly pathologic and something is very, very, very wrong. Often they have right bundle branch blocks. On top of that, at least a third of the pediatric patients have previous dual chamber pacemakers. So you can't use QRS duration in a patient who's being ventricularly paced. It's going to be long to begin with. Mechanical dyssynchrony, and you'll see a little bit of my bias here. Mechanical dyssynchrony is using echo in all of its various forms, whether it's velocity vector imaging, tissue strain, tissue Doppler, or 3D, to see is there a mechanical dyssynchrony of the heart? Does the heart basically not work together as a pump? The writing group on adult CRT said the majority of studies have used tissue Doppler to assess LV dyssynchrony, and it is the consensus of this writing group that this is the preferred approach for deciding who should get a CRT device. That was followed 2 months later by an adult trial called the Prospect trial that looked to see, okay, if I do echoes on everybody before CRT, can I predict who's going to respond and who's not going to? They used tissue Doppler, by the way. So it suggested that they were unable to distinguish responders from non-responders to a degree that should affect clinical decision-making. Thus, current clinical criteria, including the ECG, remain standard for CRT selection. We just went through why that's a bad idea for kids. So, electrical dyssynchrony, QRS duration is a surrogate. We know that QRS duration doesn't predict if you respond. You can be a narrow QRS and have a response to CRT. You can have a wide QRS and be a non-responder. And we know that whether you're a responder or not, your QRS is going to shorten as soon as you get the device.
So how is response defined?
People define response in a lot of different ways. Some people use ejection fractions. Some people use reverse remodeling, or they actually measured the left ventricular volumes and see if there's a shrinking down. Because with this poor function, you typically get LV dilation. So people are using one or the two. What people haven't used is symptoms. Nobody's actually ever looked at the symptoms, interestingly. So the problem is that we need an objective measurement for electrical dyssynchrony. And the assumption here, and I concede this, is that mechanical dyssynchrony is largely the result of antecedent electrical dyssynchrony. So we thought, well, we should make an electrical dyssynchrony index. And we're going to make that index a standard deviation of activation times from 500 epicardial sites on the systemic ventricle. We played to our strengths. The normal values, we looked at the wolves, we looked at the old data from CASE, and we were able to come up with a control group of patients with no heart failure and structurally normal hearts, and came up with abnormal value being greater than 24 milliseconds. So we said normals are less than 24, abnormals are more than that. So the projects on this, you can see we've looked at pediatrics with congenital heart disease, pediatrics without congenital heart disease, we're still enrolling non-ischemics. The pre-CRT implant hypothesis is that ECGI can be used to determine if a patient has electrical dyssynchrony. Quite simple. And that those patients with electrical dyssynchrony are likely to benefit from CRT. So let's take our first patient, a 17-year-old male with dilated cardiomyopathy, idiopathic, we never found out why, and a structurally normal heart. We did an ECGI wondering if he was going to go to implant. And what we found is that he had a very normal-looking ventricle electrically. His electrical dyssynchrony index was normal, it was 18 milliseconds. He had no evidence of electrical dyssynchrony. His QRS was borderline, like 100, 110 milliseconds. We started him on medications, he got better, and we deferred CRT. To this day, he's fine on medications. We then, very soon thereafter, had an 18-month-old boy, single ventricle with a Glenn, come in. And we did ECGI. I think he's actually one of the youngest patients we've ever done ECGI on, mostly because he took the leads off as soon as we put them on him. And we found that he had marked electrical dyssynchrony. So if you just look at his activation maps, you can see these huge areas of late activation here on the right lateral wall. His electrical dyssynchrony index calculated to be 37 milliseconds. This was incredibly dysynchronous. We optimized him on medical therapy and decided that once he was optimized, he was going to get it implanted. He got optimized as an outpatient and unfortunately expired prior to implant. So let's talk about the implantation procedure itself. Our hypothesis is that by defining the electrophysiologic substrate, we can identify areas of late electrical activation that might be suitable for lead placement, as well as potential lines of block and scar. This is very important. Resynchronization leads, we think, should be optimally placed in areas of late activation, and that they should be placed in areas where they're able to recruit large portions of ventricular myocardium. And then finally, as I mentioned before, given the restrictions of the coronary venous anatomy for transvenous implant, the decision of where to place the lead may drive the need for an epicardial versus transvenous lead. This is like heresy, right? Because we all love putting in leads in the clinical world. So let's take this patient. This is a 6-year-old patient with congenitally corrected transposition of the great arteries. So he just has ventricular inversion. Okay, he never had surgery before. He had developed heart blocks, so he got a dual chamber pacemaker and was coming in with increasing heart failure symptoms. So they said, evaluate this kid for CRT. So we went ahead and did an ECGI, and what we found was that this asterisk marks his pacing lead, was that he was incredibly dysynchronous. His electrical dyssynchrony index was 36 milliseconds. He has this huge area here of late activation, sort of in the basal left lateral portion of the heart. So we said, yeah, this kid might benefit from CRT. We also knew in our minds that kids who have this pacing system, just a dual chamber pacing system, do terribly with this. Let's implant him. So we did. And we asked the surgeons to put that lead right where the area of late activation was, and he did. So condition number 1, C1 here, which is the optimal CRT settings, actually show a quite good or quite homogeneous looking activation map with an electrical dyssynchrony index of 21 milliseconds. Similar to the CRT nominal map. This is just the baseline settings that the companies decide are a good setting for 7-year-old females. Condition number 3, which was pacing the pulmonic ventricle, the subpulmonary ventricle, showed an increased electrical dyssynchrony index, as did pacing the systemic ventricle. Interestingly, the day he came in, he had sinus rhythm, so we were able to get an ECGI and sinus rhythm. His sinus rhythm was very normal with, and looks somewhat similar, in fact, to CRT optimal settings. His electrical dyssynchrony index here was normal, 23 milliseconds. So this was a kid who was a relative responder electrically. Now, clinically, he's done incredibly well. He's actually been able to get off his heart failure medications, and he's a rambunctious little 8-year-old. So, after we've implanted these kids with devices, we hypothesized that the QRS duration is really not an adequate marker for electrical synchrony. And that if you were able to reestablish electrical synchrony, that mechanical synchrony and therefore hopefully clinical improvement is going to follow. And finally, that intraventricular optimization, or the VV optimization, is an important part of resynchronization therapy. In the non-ischemic study that we are still currently enrolling patients in, we actually found that there is a strong correlation between mechanical dyssynchrony and electrical dyssynchrony, regardless of the modality of pacing. So CRT pacing, LV pacing, RV pacing, and native rhythm. We found that there was a weak correlation between electrical dyssynchrony and QRS index, and no correlation between mechanical dyssynchrony and QRS duration. Getting back to the kids, this 6-year-old female with complete congenital heart block who had a dual chamber pacing system since the time of birth developed dilated cardiomyopathy, so underwent evaluation for CRT, got upgraded, and we thought, well, that'd be interesting to study. So here we have her in her optimal CRT settings, and we see that this is, again, a fairly homogeneous looking activation pattern with an electrical dyssynchrony index of 24 milliseconds. Whether we pace the LV or the RV in this patient, the dyssynchrony indexes increased. Clinically, she's a responder on no medications and doing incredibly well. And there is, in fact, great debate in the pediatric EP community as to whether or not all patients with congenital complete heart block should, in fact, be primarily CRT paced. The next two kids are actually very similar. This is a 21-year-old single ventricle who's had a Fontan and had a dual chamber pacemaker who developed heart failure and got upgraded to a CRT device. If we look at her first setting up here, we find that it's incredibly dysynchronous, right? We have a pacing lead here and pacing lead here, so this is her CRT settings. We have this huge area of late activation here, and this area of early activation encircled by these lines of block. The second condition is just pacing off her anterior lead. The third is pacing off the posterior lead. Any of these conditions leave her with a very, very high electrical dyssynchrony index. And what we found from this patient was, even when you IV paced her, or CRT paced her, we weren't capturing this huge portion of ventricular myocardium. The leads just weren't in the right place for her. We didn't know that going into it. We did our best. We put the leads 180 degrees apart, what the rest of the world is doing. But when we know the electrophysiologic substrate, we could probably do this a little bit more intelligently. This patient was a clinical non-responder to CRT and went on to heart transplant. If you compare her to this patient, this is a 17-year-old girl, also a single ventricle, also a Fontan, also had a dual chamber system that was upgraded to a CRT device. And if you look here at condition 1, this is her CRT optimal settings. This looks much more homogeneous. And in fact, her electrical dyssynchrony index is 18 milliseconds. Condition 2 is her nominal CRT settings, which also look pretty darn good. When you look at either anterior or posterior lead pacing, which are these bottom two conditions, you can see they're more heterogeneous, and they both have higher electrical dyssynchrony indexes. This patient is a clinical responder. So this really speaks to the fact that you really have to understand your patient's electrophysiologic substrate before you just go slapping leads in.
I have a question.
Yeah.
In the previous example, do you know if those lines of block were structural or functional? What is the kind of, structural analysis
I bet
that
it's a
these
little bit
kids
of
have?
both. So, being that she was this old, she probably had some ventriculotomy scars. Surgical technique has evolved over time. So there's been a big era where people have really been avoiding making these ventriculotomies, and within the past, I would dare say, like 6 years, people have gone back to making ventricular incisions. So I imagine that we're going to see some of this go away and it'd be more functional, and then as that generation grows up, this group of young babies right now, as they grow up, they're going to have a lot of anatomic scars. So I can't be certain is the answer, but I bet she has some of those. So in comparison, if we just look at QR restoration, electrical dyssynchrony, which I think we can measure using ECGI, and mechanical dyssynchrony, which we all know that I don't like echo, we can see that cost, sure, it favors the EKG. Objectivity, though, yes, the EKG, but I think the ECGI too. Risk to patient, well, I don't think I need to really provide risk or heart to patient. Predicting response, this is where I think is a big role for ECGI. I think that this is the only way that we may be able to predict response. Now, we haven't looked at it prospectively, but I think that there may be a role here for it. Lead site selection, I can make a very good argument in my own head at least, that ECGI may play a very important role in this. People make the argument that echo might help, but nobody's been able to reproduce this one person's data. And then optimization, which I think may also have a role. So in conclusion, ECGI may help to correctly identify patients who would benefit from CRT by excluding those who have no electrical dyssynchrony. It may help to guide resynchronization lead placements in the areas of latest activation and define the electrophysiologic substrate, and then finally to optimize electrical synchrony, which may correlate with a good clinical response. In future directions, we really should look at the Eldred ventricles and the single ventricles a little bit more. Nobody really understands them very well. And do some prospective studies. There may be a role for some minimally invasive stuff as well. And then any non-radiation imaging modality for heart torso geometry would be greatly appreciated. Finally, on behalf of Subham, we would like to thank Dr. Rudy and the lab that was back in ECGI with all of like 4 people. The group at the children's side, which includes Dr. Cantor for giving us patients, Ed, our previous EP, Tammy and Tim, and then over on the adult side, Russell, Pam, and Tim.
Okay. Thank you. So are there any questions or comments to both?
I have a question.
So you know this electrical delay thing, you said about 20-40 normals, and then you use that as the index, which you tweak your things and you try to get. Can you make it 0?
Can we make the electrical dyssynchrony index 0? Well, but there's a normal dyssynchrony, right? There's a normal level of dyssynchrony within the heart. So we don't want to overcompensate for that. We're just trying to
Why
limit.
not?
Well, because I don't think, just with conduction delay, I don't think you'll ever get an electrical dyssynchrony index of 0. There will inevitably be some transmural delay.
So let me say it more clearly.
Okay.
So in a normal heart, presumably the delay is related to how fast, you know, the myocardium depolarizes from one point to another, or from one chamber to another. So it's like a velocity of propagation in a certain direction. When it comes to the congenital hearts, especially after they've been surgerized, the basic normal physiologic concept, which drives the whole thing, which I think is sound, may have to be relaxed. And so I would, at least theoretically, consider thinking about, is it possible to make the interval smaller and smaller and just see what happens? I mean,
Yeah.
the right place to do it is in the lab. Everything's under control, and you can see what happens. And the justification, at least conceptually, is that the congenital stuff is so messed up, or at least modified enough away from normal, then the usual rule of 24
Yeah.
or close to it, maybe you just have to relax it.
No, I now see exactly what you're saying, and I think that there is a role for it. I think it's going to be a little more involved, and I think what it's going to involve is something along the lines of true multi-site pacing. Okay? Now, I've tried this in some pediatric patients, and it's frightfully difficult because of the wiring, in all honesty. So the maximum that I can get are 4 ventricular sites paced. And I've gotten as many as 3. I've not had a surgeon let me do 4. Totally honest
For
with
the
you.
normal
But I
heart.
agree. In theory, I actually think that that's the way to do single ventricles.
For for the normal heart, you don't want to have 0.
I know that.
Because-
Yeah, yeah.
because you
No,
want to
no.
have progressive.
Of course, you want to have it go, you want to have it squirt like this.
But what you,
I know.
Otherwise, it will not.
Right, it won't squirt right.
And for those congenital cases, I think each one of them has to be evaluated separately.
Of course, I was just leading into my whole advocacy for echo and the mechanics.
No, I know.
no, but see, here's what for instance, I'm not going to find it. In this patient, I think that, so we have a lead here, at this white asterisk, and here. We needed a lead here and here.
Sure, no, right, I agree.
Right?
Right.
And what we needed to do was wire all of those leads together and put them all in. I agree. I think that this is the way to do single ventricles. Actually, I just can't, like I said, I need a surgeon to have a little bit.
One day they'll have wireless, basically.
Yeah, but even if they do, I just need them to all go, what I need them to do is be able to offset them. So areas of very diseased myocardium.
But when you do it, you can't do it bluntly. You really have to see what
That's
it
right.
does to pump it.
That's right. The other thing that I think is going to be very interesting that we don't know is what are our transmural gradients in these very, very diseased hearts. Because I bet you that they're just going to be higher than in a normal heart. And so we may have to do a little more offsetting than we're used to. Oh no, I actually completely agree with that.
Any other questions or issues?
I have a question. You partially answered it already, but I was wondering if there are any factors you found that were associated more highly with electrical dyssynchrony. Did you find any on hand that didn't have?
We haven't started looking yet, in all honesty. I think it would be a really interesting question. I think that we're going to find a lot of these single ventricles have I think that we're going to find a lot of these elbow ventricles have the same problem, and that's why pacing them is so problematic.
Can you assess AV synchrony as well, or?
We haven't done AV synchrony, although this is the role for echo. There's a great role for echo in doing AV synchrony. I give it to them. Too much work for them.
I don't know why I never noticed it before, but in noticing the ARI measurements, in your during pre-excitation and immediately post-ablation, almost looks like that prolonged ARI wraps all the way around both valve annuluses.
The whole base of the heart.
Which seems a but that's not, doesn't go with your activation pattern, which does show from the WPW site around the apex back up the other side. So it doesn't seem like a pattern that corresponds to any particular region of activation sequence. I don't know, I really never picked up on that before. What do you think of that?
So you're talking about why this is like all red all through the annulus. So usually like for the normal ventricle without any pre-excitation, usually the base has a higher ARI or action potential duration than the apex. So the dispersions, the gradient of ARI is from base to apex. So in this case, I mean these values are due to the pre-excitation probably. Here the left annulus. The annulus is early here, and that's why the ARI is more prolonged than usual. But when they restore the normal sinus rhythm and the gradients come back after a month, you still see that this whole area, around the annulus, actually has a greater value of the ARI compared to the apex. But we are sort of talking more about the changes in the gradients from base to apex, which are normalized after a month.
If we go back one slide, the entire annulus is not activated early.
So this is actually, we haven't put the activation map here. We're showing like potential maps to sort of localize the, but I agree, I mean the whole annulus may not be activated simultaneously, but I haven't had the activation map for this case, but probably it's early enough, still early enough compared to the apex.
From here you can't tell.
Right.
These
I'm
are
sorry,
potential maps.
Right, I understand that. Did you not show any activation isochrones today?
So not for this patient.
Okay, I'm sorry, I missed that one.
You thought this was isochrones.
This whole annulus is, I don't know, isochron map is activated early.
Yeah.
Okay.
And the T-wave memory that you see gradually changing, is that an endo to epi change in the way the repolarization proceeds, or is that more basic?
Yes.
Connexins and the rivets that holds the cells together and stuff like that?
I think, I mean, this is just observation on the epicardial surface. We really can't see transmural changes in repolarization using the ECG technique, CGI technique. But I think that it's going to be more basic in this case because we saw a very long, prolonged ARI, and it will be shown in many modeling studies that actually, if you prolong the ARI, your electrogram T wave actually undergoes an inversion. So this prolongation of the ARI that we observe at the pre-excitation site may have to do something with the more basic, like change in the activation sequence of the particular region.
So the reason I asked, right,
Yeah, I
is because
think
T-wave
that-
inversion in a normal ECG setting is usually, at least in ischemia and stuff, it's usually a endo to epi change and
I
things.
think there is a whole thing here about this. Yeah, I have to be very careful because Charlie and Silva has done this whole thing of endo to epi, and it's a little bit misleading. I mean, it's very important and it's very correct for a wedge of myocardium, but not for the whole heart, because the electrocardiogram is an integral of the entire heart, and Jane can tell you that there is heterogeneity not only from endocardium to epicardium, there are heterogeneities just as much in terms of action potential duration, let's say, between apex and base. And we integrate over the whole thing to get the electrogram and the electrocardiogram. What Charlie did is very nice and very important, but it's basically taking a wedge out of the heart, and then you really don't have any other gradients except endocardium to epicardium. And it's important because there it's easy to identify what's causing what and kind of the timing of things and so on. But it's not the heart, it's a piece of myocardium. So that's I think here it shows that base to apex is very good.
So in patients with only one ventricle, what does the ED index means? I mean, when you calculate the ED index, you have to choose two different parts and calculate the
So
deviation.
for the one ventricle, it's actually much simpler because we have basically a set of 500 points that we're computing. So there is no,
It's the entire
it's the entire ventricle.
You take 500 points around the entire ventricle.
Which surely can't be the same as people with two ventricles, but it's the best we have.
Are we more different categories?
I don't think any of it.
You had that number like is it plotted in your plot here?
Oh yeah, so for that we were using tissue strain. Which when we started that study was the way to go. I'm not sure it still is.
So how do you predict the accessory pathway is located on the endocardial and epicardial side?
So we are actually imaging the activation here on the epicardial aspect of the anemia. So we can't image endocardial activation. But sometimes, I mean, we hadn't have a lot of cases of epicardial pathways, but sometimes from the morphology of the electrograms, it's possible to sort of predict if the pathway is endocardial or if it's subepicardial. For example, in this case, the particular example that I showed here, you see like a small R wave deflection, a small positive deflection before the big S wave. So this probably reflects endocardial, like reflects the positive potentials while the wavefront is proceeding from the endocardium to the epicardial. So this was an endocardial pathway in all probability because of this small R wave deflection. But we haven't had the chance to evaluate this consistently because we don't have enough epicardial pathways to sort of verify this, whether we can distinguish between epicardial and endocardial pathways from electrogram morphologies.
But
We've done a lot of other cases where you have, if there is no activation coming towards you on the epicardium, then the electrogram will be completely Q wave. It will be all negative because there will be no positive deflection preceding the negative deflection. It'll all be a wave going away from the epicardial side, which is basically seeing and sensing the negative tail of dipoles. So that's epicardial is always pure Q wave. If you have an initial R wave, that tells you that it's coming from the depth of the underlying myocardium. So that's how we distinguish between them.
So it's
Not only in WPW, but in many other cases.
So
the
instead
local
of the
electrogram.
activation pattern.
Okay, thank you very much.
Yeah, but